This is a demo production about treatment without transport guideline. This was an initiative from the State Department of Health Emergency Medical Service Injury Prevention Branch. Guidance that was forwarded April 14, 2020. Purpose of this guideline was to evaluate and transport decisions for patients experiencing mild illness. There is no specific policy that has been submitted by the State Department of Health. There have been drafts of what looked like was guiding documents for this algorithm based on a SARS-CoV outbreak and COVID-19. However, it's in the spirit of community paramedicine that this may linger or this may continue. I'm today here, my name is David Mendonça. I'm here today with Nate Dang to kind of go over this document.
Hello.
So any emergency medical condition in which the state of Hawaii paramedic standing order may be triggered, patients are taken via the 911 service provider to appropriate medical facility. It is where we're looking at a category where they have these objective criteria. You believe this to be what vital signs?
Vital signs, important signs, and symptoms.
That seem
that
to
would-
be make it unstable or
Yeah, unstable or stable.
and so when we go down through this objective criteria, we need to make sure that we're documenting and actually performing some of these assessments, including the pulse oximetry and end-tidal CO2 capnography, capnometry, to capture that data before moving to the other criteria. And it's basically because people who are patient categories and that are younger than that age bracket tend to need a more thorough workup than EMS can provide. And those outside of that age range, the upper limit, may have quite a lot of comorbidities and less of a robust immune system. So when they're negative to the category A, objective criteria, we move down to category B here. These risk factors, just again showing us the immune compromise and their comorbidities as well as the age bracket. So if they're negative to box A, but they have these risk factors, they're asking that potentially the patient should be given anticipatory guidance, and transport would be left to POV or privately owned vehicle, a third party, same-day transport or a scheduled transport. What kind of issues do you see here?
Usually, if there are stable patients that don't really display criteria within objective A, but they do have the risk factors and the comorbidity, and with a suspicion of maybe the COVID, then we would encourage patients and family members to head up to the hospital or the ED or the local clinic via POV.
All right,
Yeah.
yeah, that sounds like somewhat of a working plan. The scheduling the ambulance transport would require them to call through another dispatching center and then schedule that. And then a third party, the transport we're looking at potentially maybe something like Department of Health or some other group that has the ability to transport the patient appropriately. Activating or following this criteria in box B would require to contact base station physician and to confirm that there's a patient care plan and disposition that the patient can follow through. Medicom base station physician must agree and acknowledge and recommend that this plan then be carried out for the conditions of non-EMS transport, so that or if they do home treatment, and this all should be documented, the plan of care, the disposition, and obtain those signatures. So at this point, if there was any type of treatment where it's using the assignment of beneficiaries, which covers this patient contact and identified patient care plan and disposition. If we move down back to box B, if they're negative to box A, they're not an emergent 911 patient requiring transport to the nearest and closest appropriate facility, and they don't have these comorbidities, they're not immune compromised, and they fall within the healthy age group bracket. Now that the decision is to have them stay at home treatment and then make an appointment with their primary care provider, given that they can make contact. So we want to make sure that their provider is available and they have the means to get to the provider and that there's an appointment that should be scheduled. Any concerns about this category?
No.
Okay, and then as we document that care plan, again, we would contact base station physician to assure that this care plan is acknowledged and recommended by base station. And in the guidance, then we would give that it appears that you do not require immediate care in the emergency department. You should seek care with your regular healthcare provider or doctor's office or clinic if symptoms worsen. If you develop shortness of breath or other severe symptoms, recontact 911, and this may need to be expanded upon by the primary care or the EMS provider, saying that, you know, heart attack, stroke, asthma, these type of time dependent conditions, don't stall, call 911.
Yeah.